Hi. Okay, everybody, good morning again. Hope you're enjoying the second day of Giant Healthcare. There are some seats at the front. Feel free just to come, take whatever seat's available. Is there one over there, maybe? One over here? And sit. There's one over here. You can sit down here. Come, Roland. Okay, great. So obviously, great session by, of course, Nora. The UCL Business School for Health, as I'm sure Nora mentioned, is the world's first such business school, purely dedicated to healthcare. Nora asked me kindly to be a professor of practice, and I've been teaching there for the last 3 years since inception. Hugely successful. We now teach people from all over the world. We run exec ed programs for major corporate clients. We just literally taught the Kuwaiti leadership team a few weeks ago. We earlier taught the Saudi leadership team in healthcare earlier this year. So we're trying to get our insights from a global perspective and bring it back to the UK. There are lots of different courses that happen, so do come and approach the team downstairs. Think about doing a course yourself as an MBA, MBA, BSc or a master's program that the school run. We even do a PhD, MD program, so do feel free to reach out to those guys. So of course this is the AI kind of show, isn't it, right? So AI is big, as you know. Over the last 2 or 3 years, the world has changed. When the LLMs came out on the 22nd of November 2022, launch of ChatGPT to the world, the genie was out of the bottle. There's no pushing it back in. The world is transitioning to a new world. Often I talk about the concept of a punctuated equilibrium. If we go back and look at society as a whole, we talk about the theory of evolution, with Darwin's theory of evolution showcasing slow change, incremental change over millions upon years. We're kind of used to Darwin's theory. In fact, Darwin was an alumni of UCL. So that's one theory of slow incremental change. What I have to talk about with AI is the concept of punctuated equilibrium. So back in 1970, Stephen Gould, who's a professor at Harvard, challenged Darwin's theory. He said the way that human beings are derived, the way that society is driven, is that we are slow, slow, slow. We go ever so slowly. Suddenly something changes, and the trajectory of the world changes immeasurably, changes in a different direction. Society changes fundamentally. For example, the advent of fire, the advent of the motor car, the plane, electricity, the computer. At each point of human existence, we're moving along, and suddenly we're transformed. And AI is one of those points. When ChatGPT came out, it showed us there's a new way of thinking, that AI is going to power a lot of the processes in our lives. So this is kind of where we are in terms of concept and the context of the world we live in. So we have a great panel. Do you all want to come up on stage? Suzanne, Sarah, and Akhil, come and join us. So let's do it in the order. Suzanne, you're first here. No. It's Sarah. Sarah, you're here. Then Suzanne. I'll keep it as the picture. That's an old picture, by the way. It doesn't flatter me at all, but hey, what can I do about the Giant Health team? All right, so we have a mission for about 40 minutes to have a wonderful panel discussion. And please feel free to think about asking questions at the end. Start formulating your ideas and thoughts, not just on the topic here, but anything you want to talk about in the future of healthcare and AI. So first of all, I'll ask our panel guests to do a quick, brief introduction to themselves and their interests, I guess, in the context of our conversation. So Sarah.
Hi, thank you so much for inviting me here today. My name is Sarah, and I'm the Health Technology Lead for Barts Life Sciences. So we're actually a partnership between Barts Health NHS Trust, which is one of the largest trusts in the country, and Queen Mary University of London. And the team that I lead looks at how we support both the development and deployment of technology across our 5 different sites. We have both external programs for SMEs, and we have an in-house program as well supporting our staff. My interest really lies with benefiting our patients and our staff, and really focusing on how do we utilise technology for the benefit of the NHS. Interests include evaluation, quality improvement, and just as a background, I'm not a clinical doctor, I'm actually an engineer.
Brilliant, thank you so much. Shafi, also thank you so much for inviting me. My name is Susanne Gaube, and I am an assistant professor in human factors for healthcare at UCL's Global Business School for Health, so where Nora just, the school Nora introduced. And so I'm teaching human factors for healthcare, and so my entire teaching is about telling our students we need to develop technology that actually works for the users, that we always have the user's need in focus and not just develop technology from a technology standpoint, from a technologist standpoint, but from a user standpoint. And so my research is mostly about understanding how AI-generated advice in clinical decision support systems affects decision-making among clinicians and how we can optimize the implementation of these systems in clinical use. Because I do see a lot of frustration between the gap of what the technology theoretically can do and what we do see implemented at the moment in clinical practice. And that, as Nora said before, that we do not see at the moment that these systems reduce workload, but actually, because of how, to a degree, they are implemented, might actually increase workload. And so that's really my focus of research. How can we optimize this?
Thank you. Hi, everyone. My name is Akhil. By background, I'm a GP trainee, and also my interest is global maternal health. I've been working in this field for the last 10 years. I do it through 2 companies. The first one is called MAR, stands for Maternal Aid Association. I started it as a medical student at King's. 7 years down the line, we've opened up multiple hospitals, providing care to 500,000 women, free maternal care, to rural villages in Bangladesh, Afghanistan, India, and I manage a team of over 250 people. The student support is quite great with us. We have 60 universities around the world supporting us. And recently, I stumbled across AI and the work it can do in, let's say, resource-limited settings around the world, where we're using machine learning models to predict high-risk pregnancies within the first trimester, and then allowing a decision support tool for the doctors over there. Hopefully, I can tell you more about that later today. Thank you.
Thank you so much for sharing your experiences. So what we have here is quite an interesting panel. We have a clinician at the coalface who's building some AI products for maternal health. We have someone who understands about the human elements of technology innovation, how we might facilitate these discussions, and someone who's here who facilitates SMEs coming into the marketplace, navigating through this myriad of complex NHS organizations. So I think it's going to be a great conversation to have. Let's start with Suzanne. Okay, so do you think AI will make us more human? No, it's just a small question.
Tiny question, of course. So I think that's a really interesting question, because in the end, the promise of this technology was always that it will reduce our workload, it will improve clinical outcomes, and might even generate additional knowledge and makes it much easier to share knowledge. And the idea was, okay, if this technology automates a lot of our routine tasks, clinicians have more time for being patient-centered, for more patient interaction, and so it should make us, again, a bit more human, a bit less focused about just administrative tasks. And I think if the technology progresses at the speed that it does, we might actually see this really, really soon. That as a radiologist, I don't have to screen every image, especially also all the images that don't show a pathology in the end, that I do have more time to really focus on the cases where my knowledge really has the most impact and where I can focus more on improving patient care and the treatment of the patient itself. So I hope in the end it will make us more human, because it opens more space for our human abilities to show again in healthcare.
And I guess that the question, of course, is when we think about clinical work, a lot of the work that we do could be automated, from taking history, from electronic health record, collecting data, writing a letter, using maybe ambient voice dictation. All the things that add to my time in a clinic could be automated, allowing me, for example, to spend more time. I remember a few years ago, so I work at the Royal London Barts Health, and a few years ago I got medical students to sit there and say, can you just time me in my clinic of how much time I spend with a patient, speaking, I'm a cancer specialist, so I need to spend more time breaking bad news, talking about treatment pathways. And then time that time, and also let me know how much time I spent on the computer, looking at results, looking at images, trying to grab the PAS system or the pathology system. And they worked out I was only spending 20 to 30% of my time actually engaging with the patient, of the time I might have half an hour in clinic. So that seemed to me such a waste of my experience and expertise. And maybe what you're saying is that that could be much better. What are you thinking about that? In terms of, look, no one's arguing we need face-to-face. It's not going to replace us, but it might augment our clinical work.
Yeah, I 100% agree with that. I don't think AI is here to replace clinicians, it's here to enhance the work. Now, if you look at it, I have a bit of a controversial opinion on this. The global health gap is being pushed forward or increased due to AI. As more AI products are being created and being deployed in urban settings, what we're essentially doing is creating a greater rift between developed world and the developing world. And if anything, the work that I'm trying to do with Gravida is to show and demonstrate how can AI be used to bridge this gap between a resource-limited setting and high-quality care. And I believe we can do that if we have these decision trees in place, decision-making support tools in place. If you look at stats and figures, there's 5 doctors for every 10,000 people in Bangladesh. Now, if we can create a system that does not replace doctors, but enhances the doctors that are already in place to help with the decision-making processes, I think that will be a new world.
Yeah, so just downstairs, I had a fireside chat with Ali Parsa. Ali, you know well, who's the founder of Circle Health, and then the founder of Babylon Health, and now has just set up a new company called Q. It's Quadrivia, which is an AI agent. I'm the chair of the clinical board, building some kind of safety around the adoption and deployment of AI. But if you think about the world as a whole, there's one major problem. There's a number of problems we have that are universal. One are workforce shortages. If you think about the NHS, it has a 1.2 million workforce, it says the 5th largest workforce in the world, after the Chinese army, the Indian railway system, and others, for example. At 1.2 million, today, we have 120,000 vacancies. 10% of the entire workforce is vacant. We don't have enough people to deploy. Out of those, about 40 to 50,000 are nurses. Another 20,000 are doctors. Many are leaving the profession. Many are going to other parts of other industries, if you like. So we have a fundamental problem. It's a shift that we need to manage. If you look at recently with the NHS long-term plan, Aradazi, of course, was at the King's Fund. I was at the King's Fund. Keir Starmer was there with West Streeting. Talk about the 3 shifts in the NHS, from analog to digital, from the hospital to the community, and of course to treatment to prevention. That's the direction of flow this government is taking going forward. And so we have these fundamental issues that we need to solve, and AI might be part and parcel of the solution. However, deploying is difficult. What we need to understand is if you've got an idea, a small startup, a company, how do you navigate the chaos, the complexity of an NHS organisation with its wonderful matrix of complexity? And Sarah's going to hopefully untangle that chaos, having been involved in these processes, yeah? No pressure, Sarah.
Yeah, that's actually a really big question, one that typically takes about 2 hours and a load of diagrams to answer.
You've got 2 minutes.
So in terms of kind of advice that we would typically be giving to SMEs who are looking at engaging with the NHS, the first is really understand who you're actually partnering with. So the NHS is actually really just built up of multiple different layers. So for example, there is site, there is service, there is directorate, there is a hospital, there is a trust. You then have your ICBs, you then have NHS England, and then within that you have different types of care, so primary, secondary, tertiary, community. And one of the very first things I will ask is, okay, well, where are you looking at partnering? Are you looking at partnering at which level? Because that is going to make a difference in terms of how you're engaging with the NHS first and foremost. The second key bit of advice is really map that pathway. So often there are tools that are implemented, say in a primary care setting, that actually the benefits are going to be seen in a secondary or tertiary care setting. And it's really important that if you are engaging with the NHS is to be able to map that and to actually very clearly say where the benefits are really going to happen. The third thing is be quite targeted. So there are 42 ICSs, and each of these are different in terms of what they are looking for. So, for example, in Barts Health, we have quite a unique demographic. We have a predominantly non-English speaking population. And we really, as an ICS system, have to think about the demographic that we are working with and the requirements of the people that we are supporting. So really understanding the system that you are looking at working with. We see a lot of companies who do come to us and expect us to kind of be tech brokers in a kind of technology role in the NHS, but that actually is not so much the case. First and foremost, we are here to support our staff and our patients. So being able to articulate the benefits that you are bringing to the staff and patients, to anyone that you're communicating in the NHS with, is really, really important. And then finally around that evaluation piece, and I really can't emphasize this strongly enough, so we are really running on a very limited budget within the health service. As a result of doing that, we can't select everything that we take forward. So it's really important that if you are looking at even running a small pilot, to have some robust evidence at the end of that pilot that says this is the benefit that we brought, and moving away from kind of we are groundbreaking, we're innovative, and being much more articulate and much more numerical about the evidence that you are presenting. In terms of things that I also would say that we have to consider when looking at particularly AI technologies, and just to kind of mirror the comments that have already been made, we cannot emphasize enough how much time is spent by all staff across Barts Health on administrative tasks and process tasks. Some of that is because we are very low staffed. But these are the things that really are getting our staff down. They're getting teams feeling like they're not supported. Anything that can kind of support with automation or streamlining processes is a huge benefit to us. And then in terms of actual deployment, it varies between trust to trust and system to system. Actually, you'll find that kind of the structures of different trusts are quite different. So, for example, I'm an expert on what the structure of Barts Health looks like internally, but when it comes to, say, Guy's and St Thomas or, say, UCLH, they're slightly different in terms of the processes internally. I would say also look out for kind of innovation teams that are actually based at trusts as well. There's a boom in kind of emergence of roles across the NHS that, like our own, are funded to support SMEs in-house to NHS organisations, and they're always a really good place to start. And I won't name drop them all at this point.
No, thanks for that. I mean, it's a complicated question, of course, but it's always thought that NHS has more pilots than British Airways. It's often the case. Everyone wants to do a pilot to showcase their work, etc. SMEs will come in, and the ICS is a very good way. Not the ICS, is the kind of Academic Health Science Network, the HSNs, a good way of introducing your kind of idea into an academic health science network, the university or hospital, and showcasing that pilot. The problem always comes when you try to scale. You try to use it in different hospitals. You almost have to go through the same regulations all over again. And you mentioned it quite well and eloquently, in the sense that it's heterogeneous. Every hospital is different regulations. It's difficult to adopt an idea. It's not universal. And that's one of the main problems. Sarah, to that regard, is there a way of saying, is the NHS flexible enough or sophisticated enough to say, here's an idea, let's scale it across the NHS? Are we in a better position now than we were, say, 5 years ago? Because that's the fundamental issue.
Yeah, so firstly, I fully appreciate that is a huge challenge. And we often hear this from SMEs, pilotitis is a huge challenge. So the first thing is procurement is changing. So there's a new Procurement Act that's coming in that should be making it smoother for SMEs in particular when trying to onboard onto different frameworks and engage with different trusts. There is a move towards the MedTech access pathway, and that's out for consultation at the moment, so that might again be coming in with changes. In terms of the scaling across multiple different sites, I wish there was an easy answer, but at present there is not a huge amount of joined up nature between the different trusts that are adopting this technology. Some of that actually comes down to the fact that in many ways each trust can be seen as kind of its own independent business and its own liability, its own risk to take on. So there's an element of if something is trialled on our site, we want to make sure that actually be it liability or other purposes, that actually we're making sure that that works for our demographic, our data sets, the people that we're working with. But I'm hopeful and optimistic. So for example, one of the things that I regularly do is I engage with other technology teams across in-house innovation teams within the NHS, which is slightly different to what the health innovation networks are doing. And we are looking at kind of ways that we can actually make this process smoother. But right now, it's still complex. And there are pros and cons to this in the sense that it does give us an element of self-decision over what we are trialing, what we are piloting. But on the flip side, if you're a developer, how do you then scale? And I think at this stage where we're currently at, my advice would be to, you don't have to limit yourself to one health innovation network, trial 15. Like, there is nothing stopping you from kind of making sure that you're selecting the right health innovation network. It might not be your local innovation network. And I think that's kind of the best starting point for now, but in short, there isn't an easy way.
That's really helpful. It is complicated, but the good news, you're in Giant. There's plenty of people out here who are doing research, academic work, who can support you through a kind of navigating through this, the NHS system and the university. In terms of research, from your side, you're an academic, right, Suzanne? What research would you recommend for a company who may be doing AI into clinical practice? What they should be thinking about? Because the problem is it's the validity or the validation and how we deploy that in a safe and efficient manner. And that's our opportunity and responsibility.
Absolutely, and we have to do better here on that side. So I just recently read a paper that only 5% of all the AI-related healthcare papers at the moment is actually used with real patient data. So there are almost no prospective clinical trials showing the real life benefit of these systems, especially when implemented in real clinical care. Not within a pilot, but actually afterwards. As soon as these systems are usually implemented in a pilot system, they are validated within the healthcare facility they are implemented, and then you often see this module drift, that actually the accuracy of the systems drops quite significantly, even so it has been validated within the system. And so that's like a really big question, why is this happening? And I would argue a lot of it is happening because the interaction between the wider rollout that is not centered around the users to a degree. Because in the pilot studies, we're usually trying to be really, really careful, having everybody on top of things, educating everybody about how the system is working. But as soon as we are going out of the pilot phase, we are not taking every clinician by the hand and actually telling them how to interact with the system. Where are the limitations of the systems? Where do you need to really pay attention? What might different data inputs do to the system? So I think this is one really big aspect, what we need to pay attention to, that we look at these broader rollouts of the systems and how we actually need to include the users of these systems. So in one of our studies we just did, we looked into the interaction between clinicians with different interfaces of support system to detect intracranial hemorrhage. And so we already saw, for instance, very basic advice doesn't benefit expert clinicians. However, if you give them explainable advice, so basically having bounding boxes around the bleedings, you benefit everyone, both the novices and the expert users. But then also, for instance, we found that under-reliance on the system is a much bigger problem than actually over-reliance. So far, research has always focused on how do we make sure clinicians understand when the system fails and can reject the faulty AI advice, and that's really, really important. But if we actually see that rejecting correct AI advice is actually a bigger problem and overall reduces the performance of these human AI teams, then we need to change our approach, because then it's about trust and explaining the decision strategy of the systems to the users so they can better verify the predictions and the outcomes. And so that really again shows us we need to go at the moment a bit away from this clearly technology-centered focus of the research to a bit more the human-centered focus within the systems to understand how we can actually produce the most beneficial implementation of these systems.
Thank you, Suzanne. So it's going to be a mixture of both. It's showing the technology that works, showing the fact that it's validated through clinical context, that it's going to be safe, efficient. There's a lot of work to be done to deploy AI safely almost. And we're very much at the early part. There's no easy answers. There are no solutions at the moment. We're all figuring it out, and that's kind of why you've got this panel discussion. To you now, Akhil, around the work that you've been doing. So obviously you've done a lot of work in global health. Even as a medical student, you started off quite early in your journey around producing a kind of maternal care in rural Bangladesh, when I remember. Now you're moving on to AI using what's called a company called Gravida. Tell us more about what your thoughts around what you're trying to achieve with Gravida, how you're going about it, what kind of AI are you using, and what the outcome is going to be measured with. I'd love to get your thoughts on the clinical side.
Sure. So we have a reach of 500,000 women in Bangladesh where we're providing this care for free. And we thought, how do we now predict complications like preeclampsia, postpartum hemorrhage, even sepsis in the first trimester? Now, what needs to be understood is the areas we're working in is very tech-phobic. The communities are very vulnerable. And so one way we're alleviating this is by co-designing this with the healthcare providers on the ground. We're using the educational seminars, the training programs to make sure what we're providing is needed and can be used on the ground. There are many stories where other companies have come in these resource-limited settings and worked, but haven't done their due diligence. To the simple fact, there was a company that came and gave iPads out with 3-pin plugs, and they didn't realize that Bangladesh was a 2-pin plug. So once the first charger ran out, they couldn't be bothered to get an adapter. So small things like that can make a massive difference. Now, what we're doing with Gravida really is using ML models to predict these high-risk pregnancies within the first trimester, and then allowing doctors through their decision support tools to help with the preventative side of this. But then as the title of today is the human equation, one way we're doing this is by building trust around technology. And the second thing is, what's the point of predicting these conditions 8 months before they happen if we don't have the system or the infrastructure in place to allow the implementation of this care? And this is why the AI that we're creating has been adapted from a social, from a culture, from a technology point of view to make sure that, yes, we are predicting these conditions, and then we also have the follow-up needed to provide this care going forward. And we're able to do that. We have a team of over 250 people in four countries. So we're working with our doctors to make sure that this can be provided. We're working with the healthcare providers. And we're also working with the public health department in BSMMU in Bangladesh to make sure that the work we're doing is both analyzed, implemented, and evaluated correctly.
Thank you for that. So you're trying to do kind of global health work using AI, using data that is data available in Bangladesh? Data is quite scatty, isn't it?
Yeah. So we're working with the Director General of Family Planning, and they have the MIS system. The data that has been collected, again, how much of that data can be used? How diverse is that set to make sure that the ML models are, accurate? Again, that's another problem that we're trying to face, and we're in the midst of solving that problem again.
Yeah, otherwise you get bias. So the question about AI producing a platform is to have the right data. UK is getting better at collecting good data, but that's the key. That good data that's accurate, that's tagged properly, then the AI will do its magic if you get it right. If it's wrong data, you encourage bias. I'll give you an example. So for example, there's a number of companies doing skin analytics. There's a couple downstairs, for example, who you can literally put a picture, you can shine the camera of a smartphone onto a lesion of skin. It tells you what it is, SEC, BCC, or whatever, or just a benign lesion. The problem, the original companies are based all the image bank on white Caucasians. It doesn't work on black people or brown people. So therefore, you've got to think about what data we collect to make sure it's useful to people that might be deployment. And those are the kind of biases that we inherently bring in to the equation. So heterogeneity is a problem in some ways because we don't have enough of it in the AI models. I was in Rwanda only a couple of days ago at the Ministerial Summit, and one of the things that they were talking about, as I share with you, one of the keynotes was talking about how we close distance with society, with one another, and the patient and the doctor. And they mentioned three things: having integrity, having benevolence, and having the capability to deliver those platforms. And by having those, they said the quality that emerges is trust. So being benevolent, having integrity, having the capability that's demonstrated validity, you gain trust. And trust is going to be the key for us in deploying AI going forward. I'd like to get your thoughts about trust and how we ensure that what we build, what we deploy, is built on trust fundamentally.
Yeah, so I think that's a really important statement, and I think trust, it starts from not just the people who are deploying it, so not just your clinical staff, all the way through to the communities that we're serving. So we'll start with kind of the clinical staff that are using it. We see a lot of people across Barts Health who are very interested in getting involved in AI. They might not know exactly where to start and how to do that. But then you also get kind of skepticism around, oh, is this kind of replacing a job? Are you trying to prevent us employing extra people? And actually, the trust for us starts by actually going to the ground and talking to the staff and saying, look, we're here to support. The AI is very much any tool that we're deploying. We want to make sure that actually it is for you. We're not saying that we're doing something to you. We're not saying that we are forcing anything upon your service whatsoever. We want to hear the problems, and we're here to help support solve them. So trust comes from, in a lot in my role, in kind of having those face-to-face conversations with people about what technology means. So I'll give you an example. We use the word innovation quite a lot. Actually, a lot of our staff don't really know what that means. And actually, that trust has kind of even just been a language change, so moving away from things that perhaps push people away to more inclusive language, such as it's technology, it's support, it's administrative support, it's quality improvement, because that's a language that is often understood as well. So there's trust internally. And then in terms of trust for people that are using any form of technology, not just AI tools, it's really about bringing them into the design, and I cannot emphasize enough. So I'll give you an example. We run a project request process for collaborations with Barts Health, and we had a question in the design section about, tell us why this meets the needs of our population, tell us about how this is designed with the needs of our population. About 70% of people who filled that out weren't able to provide a solid answer. And that was actually quite startling. These were companies that were interested in working with us. So it's not just an afterthought to kind of bring people into the design of these tools. It's absolutely essential that this is done, because otherwise it's not going to be something that is suitable. And then in terms of kind of actually engaging or getting the trust out in the community, that starts with the developers. It starts with having that patient-public involvement. It starts with the co-design. There's also a lot of work that we're now doing in my team about user-centered design. So how do we actually engage our communities? What are the digital exclusion criteria and barriers that are facing us? So it's about really bringing in that human element, where technology is amazing, but humans will trust other humans, and you have to talk to people. So.
Thank you. So when we talk about technology, sometimes what we forget, we talk about patient-centered design. Great keyword. We're patient-centered, we're patient-focused, in reality, we're very rarely patient-focused. We're very rarely patient-centered. In fact, if you look at this room here, how many patient participants are here? We're all patients, but how many representatives of patient associations represent us? And so I remember I do a lot of talks around this, of course, we talk about in computing language, the terms UI and UX. And most people know what it means. UI is the user interface, UX is the experience. That's what we should be thinking about when we deploy a patient platform, is the PX and the PI. What's the patient interface? What's the patient experience? Change the framework of computer language into health language. And that is the center for us to think about how we use patient-centered approach in everything that we do. We're almost ready for questions, so think about some questions. I'm going to come to you in about 30 seconds, so think about raising. Trust from your perspective, what does it mean?
Yeah, so I think trust is really among the key points in this world of implementing AI technology that per se is not built for trust. It's very obscure, it's very unclear how these systems work, especially if you don't have a computer science background. And so what we saw, so that clinicians are much more interested in giving the benefit of the doubt to the system and trusting the system if if they are tested in low-stakes environment. Why, for instance, clinicians are really excited about a system that takes over administrative tasks and then builds trust when they see it works. And then if you then ask them, would you be open to now, let's say we implement a system that helps you in diagnostics and helps you in treatment prediction and prognostics, if they've already gained the experience from a system that helps them with administration, they are much more open to the systems, and then they gain much more trust in. They might not have to understand the underlying functionalities, but they've seen it work for them in low stakes environments, and now they are much more open to implement it in high stakes environment. And it's similar to patients that if they see a system working for them, they do think there will be a benefited. And so I think this understanding where it comes from and understanding how it could help me with small bits and pieces of my work will in the end increase trust overall in the systems.
Thank you. Akhil, from a clinician's perspective, what does trust mean to you and AI? Because you've got a responsibility as a clinician, you've got the governance around this, the accountability, the GMC on your shoulders, all right? If you get it wrong, what does that mean to you? Trust.
No pressure.
Yeah.
Trust, in simple terms for me, is action. Leadership from the front line. There are two organizations that I follow quite closely to understand how to build trust and build action. One of them is BRAC, with Sir Faisal Hassanabad. The creation of the BRAC system was when there was a cholera outbreak, he went over there and through the oral rehydration therapy, a simple solution like that built trust in these communities. So when he came with a new intervention, it was taken up very fast. And the second company that I follow quite closely is Arivand, the biggest provider of eye care around the world. They see over 4.5 million outpatients every year. And they started off in a small remote area in India, and now they've turned into a case study for Harvard Business School. And the way they did that is through the trust that they gained by providing all the care that they did, subsidized or at free cost. And then they went over and they're providing these mobile clinics, they're telemedicine, they're creating their own intraocular lenses. And that is, again, built through trust, through action. And that's, in simple terms, what I think trust is the basis of.
Thank you. I like that. Trust through action. That's a really nice term to use. Right. Audience, are you ready? We have a hand. Do we have a roving mic? Anybody? Do you need one of our mics? Take one of our mics. Sorry, Sarah. We'll share. Please. You just want to introduce yourself first of all. We're coming to you next. Roland.
Yeah, thanks. Quick two questions. You've talked about trust. In the context of AI, you haven't talked about safety. So my first question is, how important do you see safety as a variable when looking at AI? The second question is possibly more specific to Sarah, given her wonderful description about the procurement process, et cetera, and thinking about AI specifically, do you see adoption of AI in any healthcare system, let alone the NHS or Bart's Healthcare, being driven by specific use cases where you have brought on board the relevant stakeholders and the safety dimension has been covered adequately?
Okay. Or
at a higher level, do you expect the more resource setting that Akhil talked about, or removing through AI, or building common knowledge bases through AI would be the other angle?
Okay, thank you. Safety, Akhil?
So I'll do it as a rapid fire answer. The safety of it, in the UK, there's a lot more law, let's say, we're still creating, but there's a lot more laws around AI. Now imagine in a resource limited setting, those laws have not been created yet. Those legal structures have not been created yet. But just because those structures are not created yet, I have a duty as a clinician to make sure I'm maintaining my ethical duties. There are two ways I'm doing that. I'm working with the government directly, with the Director General of Family Planning, and I'm also working with the Public Health Department to make sure that even though these rules are not created yet, we're working in a safe and ethical parameter. And we're kind of learning on the go, to be honest.
Right. Sarah?
So in terms of the second part of the question, so is what you're asking, is it driven mostly... by specific use cases internally, or is it more driven by the companies externally? Is that kind of the question? Yeah, so I would say it's more driven internally, to be honest, in terms of the drive for deploying technology, AI tools. So, for example, one of the things would be that we have to look at whether or not this is aligning against our priorities, whether or not this is kind of in our strategy, whether or not there is a supportive team. So often the adoption of technology really depends on the people as well. So is there a clinician? Is there a QI team that are kind of backing the support? We're actually moving much more towards focusing on those kind of bottom-up as opposed to top-down technologies. Now, that's not to say across, say, NHS England, what might happen with, say, the future of the MedTech funding mandate or the MedTech access pathway might change. Yet to know exactly how that's going to work in principle, but if you're not having that bottom-up approach, what we found is it's really difficult to make anything happen. So as you can probably imagine, if we were to go out and say, actually, do you want to engage with Barts Health Trust, we are absolutely flooded with requests, but that doesn't necessarily actually result in kind of successful deployment. Whereas if we have a team who has a challenge and we are there working with them to solve that actual challenge, be it through a technology solution or otherwise, to be honest, because not everything even needs technology, that works much more effectively. And one of the kind of, one of the statements that has really kind of stuck with me since kind of starting at Barts Health is very naively at the start of my career, I went to talk about I spoke to a clinical lead about a technology that actually had approached us. And the answer I got was, Sarah, we don't even have functioning Wi-Fi on laptops. Can you help us solve the real problems? And that's really stuck with me because actually the real problems, it might be administrative, it might be something that we think could use technology, but it turns out it's actually more kind of operational process driven. But I would say bottom up is definitely the route forward.
Thank you so much. Right, over here, but to the right. Just introduce yourself and ask the question, and keep it short, otherwise we're out of time. Thank you.
Hello, my name's Grant McKenzie. I'm co-founder of Comfort Companions. We've developed a non-clinical tool to be used by elderly patients who are facing cognitive decline to help them better manage their care experiences. So it's a memory support tool as well as a companionship aid. So a lot of the points you've been making have really resonated with me. One of my biggest questions in the event has been, there's a huge focus on the clinical side of it, yeah? So looking at how it can be used to help support decision making. Where are the use cases as you're seeing them for non-clinical use? Because obviously the NHS is a huge organisation and there can surely be many ways in which AI can be used effectively to help improve the patient experience in non-clinical ways as well.
It's a good question. I think most AI that you will see that were deployed won't be clinician-facing or clinical-facing. It'll be the back end, the automation. If you think about ambient voice dictation, we're now seeing people deploy voice dictation where the AI picks up the conversation and then makes it into a conversation piece and summarizes it, for example. We're seeing AI now being deployed into the electronic health records. So if you look at Oracle have taken over Cerner. They bought out Cerner for many billions as a health record. If you look at the latest iteration, which will be launched next year, it's got ChatGPT-enabled LLMs into the EHR. So we have to ask the question, it brings out data from the EHR and summarizes it for you, for example, yeah? So voice dictation, AI-driven pathways. We see AI now trying to reduce the beds, for example, improve bed base, okay? With dashboards, looking at flows of patients across the system, right? We're seeing AI also being used for, for looking at appointments, missed appointments. How do you get rid of appointments that are missed, the DNAs, and how do you make those appointments much more realistic and less wastage being used? So those are the kind of things we're seeing all the time. Any other things that you've seen? Non-clinical facing examples?
I think you covered quite a lot of them. I think there are some of them that are more patient-centered. For instance, you said there's some of the diagnostic tools that are really used by patients and that immediately have some like small intervention, small treatment, but so they're not for clinical use or clinicians use, but for patient use. But yeah, otherwise, mostly I think administration, logistics. I think there are a lot of projects in sustainability. how can we, especially as healthcare institutions, be more sustainable, and how can these large language models or other systems help us develop better sustainability processes?
Okay, we're kind of out of time, is that right? We're being ushered off the screen. So I'd like to say huge thank you to a wonderful panel. A round of applause, please. Right, I'll make way for, it's Gordon, isn't it? I think it's next, right? Is he here?